Hello, everyone. I'm Dr. Carmen Puliafito, and I'm here with my co-host, Dr. Charles Wyckoff. And we're happy to welcome to Retina Synthesis, Carl Danzig from Pompano Beach, Florida. Carl, welcome to Retina Synthesis.
Thanks for having me here, Dr. Puliafito and Wyckoff. It's a real honor.
Carl, great to have you, man. Great to be on this with you. We've known each other a long time. So you're doing important work out there as always. So we have Faricimab that's FDA approved for 2 indications at once, been that way for a few months now. And you guys have put together by far the largest series of real world experience with it. This is important because the last drug we had in retina didn't go so well. Real world experience found some side effects and some problems with it, but this is a very different story. Really exciting data, really important for doctors. Tell us what you're doing and what you found.
Right, so you're 100% correct. One of the reasons that we put this together was to show the retina world that, what the real world shows, what our data shows. Now, this is not a durability study. We talked about safety and efficacy in the Truckee study, which I talked about and presented at ASRS a few weeks back. So with this, study, it's basically a collaborative effort of physicians. It's not pharmaceutical sponsored. It's our own endeavor to collect data. And what I presented was basically, there were 770 injections, and we looked at 421 eyes. But then we looked at those patients that had follow-up, who had a faricimab injection and came back. And then we saw that was about 236 eyes of patients at 2400 vision or better. And the reason we chose that was because we were converting from Snellen to EDTRS, so it was a little easier that way. And we found good results.
Tell us about that. Tell us what your safety endpoints were, what the efficacy signals were. We think an anatomy here. Where did you see a benefit? Right.
So excellent points, excellent questions. So we looked at demographics, we looked at prior treatment history, and what we found in the patient population now, most of them were switch patients. There were 28 treatment naive eyes, of which we had follow-up for 16 of them. So 236 eyes had follow-up, 220 were previously treated. So most of the patients were those tough to treat, high need patients, the ones that we all have in our practices that were like, these patients are getting injections every 4 to 6 weeks, and these patients aren't getting younger and they're not getting healthier. And these are the patients that want to have something else. And many of these patients were already stable. So we were not expecting, big visual gains here at all. Right. We were hoping that with this new drug in those patients that we'd have stable vision and good safety. And that's what we found. We did find some improved anatomy in terms of CST and PED height. It was modest, not a lot. In the 236 eyes included treatment naive, it was about 32 microns decrease of CST height. And that was a little bit less in the previously treated, as was expected. But the vision stayed the same. And what we saw were 0 cases of IOI, no cases of intraocular inflammation, no cases of occlusive retina vasculitis. There was 1 case of endophthalmitis that was treated with tap and inject, and that patient's vision returned to baseline. Good. But overall, we were happy with these results, and
congratulations. It's an important data set. So a practical question for you. I'm having similar results with faricimab or Vabysmo in my clinic. I'm having good anatomic outcomes, no safety signals. Love this data that's conglomerate over many doctors. What about the flow of clinic, right? You're used to using your pre-filled syringes, and now you got to go back to the vial. I'm serious. Is that a challenge? Should we worry about having to do that and the small risk of, infection? Should doctors wait for a pre-filled syringe? What's your thought there?
Look, we've all dealt with vials for ranibizumab, aflibercept, brolucizumab. The vials were not the issue with brolucizumab, as we well know. So, I don't even think twice about it. Do I like a pre-filled syringe? 110%. It helps my flow. I think it's just easier. It's boom, boom, boom.
Yeah.
But, often, my practice uses some specialty pharmacy drug that we have to use. And that comes in a vial and we make do. And I, in the end, care what I think is most efficacious for the patient. And I don't think safety is compromised really in the end by using a vial.
Yeah.
So what about durability of this treatment response? Any insights from Truckee?
So from Truckee thus far, no, because my presentation was really about the safety and efficacy after one injection. Now, this is very early data, and we're hoping for other retina meetings like Retina, AAO, and next year, hopefully we'll have more opportunities to present and we'll look at durability. I mean, I have some patients that have had 4 injections that were tough to, these tough to treat patients, but that wasn't included in the study. That wasn't part of the data cut. So it wasn't about durability, but, I'm hopeful, especially when I look at my patient that was treatment naive that had a great anatomic response. Granted, her vision didn't improve a whole lot. I think that's more of the nature of the disease. But when you see that kind of response, you're hopeful that durability will follow suit. It's just too early to report that.
What about anatomic changes? I mean, in eyes with chronic intraretinal fluid, subretinal fluid being treated with aflibercept, were these eyes amenable to resolution with faricimab?
Oh, yeah, they absolutely were. I mean, and often, it's the patient's, anatomy that will dictate it and the type of their fluid. We had a case of from Dr. Kanani's practice where the patient had, intraretinal fluid that went away quickly with faricimab, the same interval. And that was one of the keys in Truckee, is that the intervals were kept the same from the prior treatment. I had a patient that was tough to treat, who had chronic subretinal fluid. Now, I think it's important, to have stable subretinal fluid versus these fluctuations for any of our patients on whatever drug they're on. And, Justice Ellers talked about that at ASRS also, very nicely, actually. And, what I found with my patient who had been treated for 9 years, okay, he had been treated with all the drugs available. He's 94 years old currently. He started when he was 85. And he was even enrolled in the Merlin study at one point. He was then given Q2 injections that had no response. He was alternating, BUVU to Eylea, alternating months based on the label. And he had no issues of intraocular inflammation, but he never had fluid resolution. After his first faricimab, at the same interval of about 33, 34, 35 days, something like that, his subfoveal fluid resolved for the first time. Now, his vision stayed the same. But, that patient's hopeful that, hey, I'm 94, hopefully they don't have to see my face every month anymore.
That's exciting. You guys are doing great work. Thanks for organizing this series. I think it's really helpful for clinicians to get this early real-world data that it's safe with comparable efficacy, if not a little better drying component, which we look forward to learning how that translates to durability. Thanks for the work, Carl. It's great.
No, my
What
pleasure.
do you think? What do you think about the positioning of faricimab in a year from now? Where will it be in the treatment hierarchy?
Well, I think that all patients that were tough to treat, that were getting 2 to 4 week, whatever injection it may have been. And in Truckee, those patients, 66% of them were switched from aflibercept, from Eylea. But I think all of those tough to treat patients are going to be switched over. I mean, and why not? Why? As long as the patient's comfortable in it being switched over and the doctor's comfortable, and I don't see why they wouldn't be, those patients are going to be switched over. Is it going to be first line? I think for some doctors, yes. I mean, maybe doctors who are using, Lucentis commonly and felt comfortable with the Genentech product would move to first line Vabysmo. But I think first line, any of the drugs, people generally have a decent response, some better than others. And the question is, and we're going to learn more about the Ang2 component to Vabysmo. And that may dictate where, the position of this drug will be in the future. Seeing stability after the loading doses, seeing how many patients we can get out to, Q12 and Q16 weeks safely, will dictate where this is. We know the 2-year data from view 1 and view 2 that, we had a fair amount of patients in the second year that were able to get out to Q12 weeks with Eylea, which is a fantastic medication. But for those patients that are stubborn with recalcitrant fluid, I think Vabysmo is going to rise up the ranks for that type of patient, especially.
Good insights. I agree. It's nice to have another tool in the toolbox. There are a lot of patients that are getting frequent injections with Lucentis, Eylea, or Avastin looking for something else. It's nice to be able to offer them something. I completely agree.
So how many investigators are there in the Truckee trial right now?
About 15.
And
we're adding some actually in the meantime. People have come up since ASRS and want to join.
So, and the horizon for this is several years of follow-up?
That's the goal. And we also want to add DME patients to a sister study called Tahoe that's being organized currently. And we haven't talked yet about DME, but we want to have data for both disease states, over the years, showing safety, efficacy, and durability, and just seeing where things play out. Because the real world is not a clinical trial. The clinical trial was an excellently, the Tenaya and Lucerne trials were wonderfully designed, and so was the Yosemite and Rhine for DME, where you had the PTI, the personalized treatment interval arms, but their retreatment criteria may be different, than it would be for a certain physician in the real world. So we're going to see how it plays out, and I think it's promising, for both disease states, and hopefully we'll have the data for years to come.
Well, thank you, Carl. This has been a great discussion, and we look forward to staying tuned with Truckee. Thank you.
Thanks for having me. I appreciate it.